refreshed with a good cup of tea and won't sleep in this boring lecture. I've chosen 3 topics today to discuss, and I'll try and make it as interesting as possible. Those are the 3: understanding a fracture, followed by a short description on fracture healing, and then I'll go through some common fractures of the upper limb. I would have liked to go through as many common fractures as possible, but I think I'll be short of time by the time I finish these. It is important to understand the fracture, and also again it's important how the fracture heals before we go on to the clinical application of how to manage something. Now, a fracture is defined as a break in the continuity, structural continuity of the bony architecture. Now, the structural discontinuity may not be visible on a normal X-ray because of microscopic break of the trabeculae, which happens with osteoporosis, pathological fractures, fractures of, for example, scaphoid. You can't see them on the X-ray unless something else happens to it. Either it starts to heal or it becomes a growth fracture. So any discontinuity which may or may not be visible is still a fracture. And these are visible when you do an MRI scan because of the local edema. Now, a fracture can be open or closed. As you all know, we used to call them simple or a compound, but now we call them open or closed. Closed is a simple fracture, open fracture is a compound fracture. And a fracture again can be a multi-fragmented or can just have 2 fragments, sort of a simple fracture. You've seen this picture, it's an open fracture, the tibia. Now, there are a few ways we can classify the fractures. One is based on the geometry of the fracture, which way you see the fracture line running through the bone. It could be a transverse fracture, it could be an oblique fracture, a spiral fracture with a butterfly, depending on how the fracture line is running through the bone. Just imagine a fracture of the tibia and imagine a line going through the middle straight, obliquely, spiral with a loose fragment in the middle, or a segmental fracture. A segmental fracture is the one in which there are 2 fractures at 2 different parts of the same bone. So there's a free fragment in the middle. These are the names which you use quite often, so just to introduce them to you. A multi-fragmentary fracture used to be called a comminuted fracture, whereas we call it now a multi-fragmentary fracture. There are more than 2 fragments, the proximal and distal, maybe one on the side, one in the middle, one compressed. Now, another way to classify a fracture again is based on the location on the bone. First, we classify it based on the geometry. That's how we classify based on the location of the metaphysis, which is the juxtaepiphyseal part of any bone. If you remember the anatomy, diaphyseal is the mid part of the shaft. A fracture in that area is called a diaphyseal fracture. An epiphyseal fracture would be in the area where the joint is, just near there. And an apophyseal fracture is a fracture of any apophysis. The example of an apophysis is either a coracoid, a tibial tuberosity, calcaneal tuberosity. So that when the muscle contracts violently, it can pull a piece of bone from where it is attached. So that's an apophyseal fracture. Why I'm explaining these to you, if you communicate by phone to somebody and tell them there's a fracture of the proximal epiphysis of the tibia, it looks like an apophyseal avulsion of the tibial tuberosity, so then it's completely descriptive. You don't have to say it in any other language. There are certain terms used for fractures as well. I want to introduce you to these miscellaneous fractures which are talked often in our community. We need to understand them and again to be able to communicate properly. A pathological fracture, you must have come across osteoporotic neck of femur fracture is a pathological fracture, or a fracture through any tumor is a pathological fracture. Stress fracture or a fatigue fracture, you may have heard of fractures of the necks of metatarsals in runners, so it's a stress fracture. The fracture of the lower tibia in runners again is a stress fracture. Again, the fracture of the pubic rami in runners again is a stress fracture. Compression or impacted fracture, an example would be a compression of the vertebra in osteoporotic. If somebody fell on their back and there's a compression of the fracture of the vertebra, it's an impacted fracture, it's compression fracture. We may not be able to see it clearly on the X-ray except the fact that the vertebral height is reduced. Green stick fracture I'm sure you're familiar with it. It breaks like a twig, a green twig of a tree. That means it doesn't completely break because the periosteum is strong. Happens in children. Avulsion fracture is like the apophyseal fracture, the same term used for the apophyseal avulsion fracture, from the tuberosity or the coracoid or the medial epicondyle, lateral epicondyle, anywhere the fracture is avulsed because of the strong muscular contraction. Iatrogenic fracture is the one which you would like to hear about. This is the one we produce when we are doing something, either manipulating a shoulder and fracturing the humerus, manipulating a tibia, trying to put a nail through it and bursting the tibia. Is an iatrogenic fracture. This is the one which is produced by you or me. Fracture dislocation, another term used when there's a fracture associated with the dislocation. If somebody is calling me and saying there's a fracture of the proximal humerus but hasn't looked at the shoulder joint, it completely changes the management if there's an associated dislocation of the shoulder, and we only consider the start managing the shaft of the humerus. Floating fracture is a fracture in which there's a fracture above and below the middle segment. For example, floating fracture of the leg would be a fracture of the femur and a fracture of the tibia. So the knee would be a floating knee. These are the terms used quite often. Intra-articular fracture, again, a fracture which is involving the joint surface. An absolute indication for either referral or intervention. There I've got a list of fractures of necessity. Before I go any further, these are the fractures which, in my opinion, should be either consulted straight away with the orthopedic surgeon in your region, because they may need surgical intervention, or at least taking an advice is mandatory on them. Any open fracture, difficult to manage in a peripheral setting, any open fracture with a wound. Now, as far as the open fracture is concerned, an open fracture could be mimicking a simple fracture by the sense that the bone only came out through a 2 millimeter hole in the skin and then went in. So you can't find that 2 millimeter hole, but there's a drop of blood in front of the tibia. This is essentially an open fracture when there's a communication between the outside or the inside. Doesn't matter what the size of communication is. It could be just the size of a needle. It could just be a real big open fracture like that you saw in the picture. So any open fracture which you suspect might have carried the bugs from outside to inside needs to be referred. A fracture dislocation, again, you can manage the fracture maybe, but not the one which is associated with the dislocation because of the added instability. You try to reduce the fracture, the dislocation doesn't stay in. You reduce the dislocation, the fracture doesn't stay stable. It's a combination injury. Supracondylar fracture in children, these are the ones which are vastly mismanaged here in our country. I've seen quite a few Volkmann's ischemic contractures, deformities. I'll show you some pictures of them, but this is the one fracture which should not be ignored. It's a very simple one to manage if you know how to, starting from the initial grading of the fracture. In this third part of my presentation, I'll explain that and try to explain it well. Epiphyseal injuries, again a fracture of necessity. Intracapsular neck of femur fractures because of the increased risk of avascular necrosis of the head. So any fracture of the neck of the femur which is intracapsular, it needs to be referred. Intra-articular fractures, as we already said. Avascular necrosis is quite common, and I've seen quite a few here which a couple of them had no other option but to do a total hip replacement. The decompression doesn't work very well if the avascular necrosis starts. So intracapsular neck of femur fractures is a surgical emergency. Unstable, especially in a young person. Unstable and segmental fractures. Unstable fracture, of course, can't be handled by either an external splint like a plaster or a traction. So they need to be either fixed internally. Segmental fractures are the one which has got a middle segment which is free. Or there's more than one long bone fracture, femur and tibia together, or radius on one side and tibia on the other side. They need to be referred. Remember, this is a list of ones which you think you must refer. Periprostatic fractures, fractures around an implant, around a plate, around a total hip, around a nail, because they do not heal unless you do an intervention. And then the pathological fractures. Any pathological fracture needs surgical intervention. They will not heal. Few examples. This fracture, if we go back to how to classify this fracture, trying to understand it, this is in the area of the epiphysis of the tibia, proximal part of the tibia. This is an intra-articular fracture, it's going into the joint. If we want to think about the line of the fracture, it's an oblique fracture. If you want to talk about the displacement, it has got slight varus displacement of the lateral condyle. That means the lateral condyle is lifted up. It has got some combination at the ACL insertion there. So, and then very likely to have an instability in the knee because of this nature of the fracture, which is intra-articular. Again, an essential referral, it needs to be reduced and the joint surface made congruent again. Just an example. Every fracture you see, think about it, where it is, what is the type of the fracture line, what is the displacement, and what else can happen. Again, with this, as we went through the other day, as to the ABCS, the alignment, the bone, the cartilage, and the soft tissue. Always remember the soft tissue. If you can see on a good X-ray, a soft tissue swelling will be visible. These are 4 things you need to see on any X-ray. And whenever you explain it to somebody, just mention those. There is an unstable fracture, an example of a bimalleolar ankle fracture. Again, see, there's an avulsion fracture of the medial malleolus. So the deltoid ligament is very strong. It has held the medial malleolus down. So now we have an example of an avulsion fracture. We have a fracture that is displaced. The talus is displaced 2 inches laterally. We have an oblique fracture of the lower end of the fibula. So there's an oblique fracture of the syndesmotic area of the fibula. The tibial displacement is medial. Fibular displacement is lateral. The fibula is abutting against the talar dome, and there's quite a lot of soft tissue swelling. Bone quality is okay. Always think about the bone quality just to decide whether it could be a pathological fracture. But this is essentially secondary to a trauma. Absolute indication for a fixation like that. It needs to be fixed straight away so that the ankle mortise is made congruent again. The vascularity of the talus is vastly compromised because of this position. It can develop avascular necrosis because it only gets blood supply from one end, so it needs to be reduced and put back into the normal position so it can start being nourished again. Unstable fracture. Pathological fracture. There's an example of a pathological fracture. This is a marble bone disease in which the osteoclasts don't function. Osteoclasts with a C. They don't function, so the osteoblasts keep on laying down the bone. The bone gets very thick and marble-like. So it's a brittle bone. This is a subtrochanteric fracture of the femur. No amount of traction like this Thomas splint, any traction, plaster will make it heal. It will never heal unless you fix it. This is a pathological fracture. Now let's talk about fracture displacement. What are the 3 forces that displace the fracture? If you understand the kinetics of fracture, it's easy to reduce them because you will know which way the fracture is going to displace. Even if you have immobilized it, so you will reinforce your splintage accordingly or decide about operating. Forces that play a part in fracture displacement are forces of injury, initial amount of kinetic energy that has gone into the first trauma, road traffic accident, high speed, fall, whatever, force of injury. That's why I try and ask the patient a complete description of how the injury actually happened, what was the speed of their motorbike, did they skid on the road for a long distance to rule out other friction injuries. So complete description of their mechanism of injury will tell you a lot. So forces of injury will displace the fracture. Gravity is another thing which will displace the fracture all the time because you can't get rid of the gravity. So when you are trying to reduce a fracture or maintain a reduction, this is one thing we have to keep in mind because it will always act. Like the muscles, and the muscles will always act. Muscles will keep on functioning, so they will pull one fragment this way, the other muscle will pull one fragment that way. So you have to counteract those natural muscle contractions. They won't stop contracting. This will stop, the force of injury has stopped, right? But these will continue with the patient until the fracture heals. Just need to consider them while treating. Now, what are the directions of displacement? This is just normal physics. Directions of displacement could be sideways, it could be vertical, it could be rotation, the worst of the all, and angulation. There's an example of a mediolateral displacement. So this proximal tibia is medially displaced, distal tibia is laterally displaced. Same with the fibular fracture. The general alignment is good. The adequacy of the X-ray, which we learned yesterday with an A, the alignment is okay. The adequacy is okay because we can see the joint above and joint below. So any X-ray demand an adequate X-ray, or maybe look for an adequate X-ray. Okay, I won't ask for another view because I can see the ankle. It is very likely if the ankle was not in the picture and there was a fracture and there was an ankle fracture dislocation with it, you will miss it. So you need to have a joint above, joint below, and then you need to have two views, not just the AP view, a lateral view as well. And as I mentioned in my first lecture, you need to have somebody else look at the X-ray as well. So two people looking at the X-ray, and then you need to look at it twice. So go again and look at it, so you won't miss anything, just for the benefit of the patient. Here it was only mainly put on to mention the displacement. This is a mediolateral displacement. Let's classify the fracture. It's the diaphyseal fracture of the tibia. It's displaced with an oblique step line of the fracture line, and it is slightly displaced medially. There's a fracture of the talus. This is a multifragmentary fracture. This is the talar dome. Part of the talus is lying here. This is part of the joint surface of the talus. Young motorbike accident. The talus has burst out from here, has come outside the fibula at the front here. So this is not only an intra-articular fracture because it's in the joint, it's also an impaction type of fracture because it has acted like a pilon, a pestle, or a mortar hit down. Talus burst open into two parts, one part came out there. So it's an intra-articular, displaced, depressed fracture of the talus. And it's also multifragmentary. There's an example of further displacement as well as being an intra-articular fracture. It's a fracture of the neck of the femur. All the blood supply to the head is temporarily interrupted. The femur is externally rotated by the fact that the lesser trochanter is more prominent. That means the foot is pointing outwards. So there is a tension on the vessels to the head. It is displaced in the fact that it is shortened. The trochanter has migrated up. See, the trochanter level is up to the upper part of the acetabulum. It should be here. Explain to you the displacement and likelihood of avascular necrosis. Now the displacement here is not only shortening but rotation. This is again an intra-articular fracture. This is an interesting fracture dislocation. It's a fracture of the ulna here. The ulna has displaced anteriorly. I'm talking about the distal fragment. Always talk about the distal fragment. So distal fragment has displaced anteriorly. Not only anteriorly, it has also displaced vertically. That means it has shortened. So it's got two directions of displacement. And I'm sure it has also got rotation. So three directions of displacement. So when you're explaining to somebody, you say, well, there's a fracture of the proximal ulna. It is still in the diaphyseal metaphyseal junction. There's a step fracture, a step transverse fracture of the ulna. The distal fragment has displaced volarward. It has gone proximally, so it has also rotated. And then the radius has gone out of the joint. It has dislocated out of its annular ligament. See, the head of the radius is left where it should be because the annular ligament is very strong in young people there, very young, epiphysis. So 17-year-old, hasn't fused yet. So the radial head is still there. It's an epiphyseal injury. Part of the growth plate is sitting on it, and the fracture has taken a bit of metaphysis. So it's a fracture dislocation. Then look at the soft tissue, a lot of swelling at the front and the back. Likelihood of nerve injury because important nerves run around here, around the neck of the radius. The posterior interosseous nerve, patient can't extend his wrist, so you know there is a nerve injury as well. Radial brachial artery being pushed by the head of the radius, no pulse. So just an examination, just looking at the X-ray will prompt you to go and look at the pulse again, go and check the posterior interosseous nerve again. And this is an inadequate X-ray, you will agree with me, because I need a wrist X-ray and I also need a shoulder X-ray. So I won't accept it as a final X-ray before I start managing it. That's what you should do. Ask for the wrist and the shoulder X-ray, and then let's decide about the management. Another example of a fracture, there's an angulation. So it's a fracture of the proximal tibia, junction of metaphysis and diaphysis. There's an angulation at the distal fragment dorsally. Distal fragment is backwards. So we call it an anterior angulation. This is the one which has got lots of displacement, but this is an example of a segmental fracture. This middle fracture humerus is a segment, free segment. There's a fracture distal, there's a fracture proximal, it's a fracture surgical neck of humerus, and the metaphysis, then the diaphysis, angulation, rotation, and shortening. There's shortening. So 3 or 4 displacements and a complicated fracture of the humerus. You know, axillary radial nerve runs here, very likely to get involved. Axillary nerve runs here, very likely to get involved. The shoulder may be out of the joint, so you need maybe another view to make sure the shoulder is still in. My next talk is on fracture healing. If you have any questions before I commence on that, I'll be happy to answer, or shall I carry on? Okay. Now, fracture healing, I won't go too much in detail, but it's quite an interesting concept how the fracture heals. And it's very easy to learn once you know these 3 steps. It heals in 3 steps: inflammation, repair, and remodeling. Inflammation starts straight away after the hematoma. When the bone breaks, there's a hematoma. Repair follows soon, the cells invite everybody else. And remodeling takes many, many years. Okay? Now the inflammation here. Simple algorithm. Bleeding happens, this organizes into a hematoma and becomes a fibrin clot. Lots of granulocytes are trapped in this, so they release these bioactive factors. I've got a list of them after, but they release these factors and they invite the macrophages and fibroblasts. This is the initial inflammation happening. Macrophages clear up the debris, they've got angiogenetic factors, they increase the blood supply, and then the fibroblasts lay down the collagen. This hematoma here is replaced by a granulation tissue. Before the soft callus, it becomes a granulation tissue. Here, at the repair phase, it starts to become a soft callus. Then we have a hard callus. That's when the remodeling happens. Now, repair is mediated by all these chemotactic mediators, which are released by these cells that are trapped in this fibrin clot, and starts the primary callus response. That's what we say, that within the first 2 weeks, the fracture is stabilized with a jelly-like material. This is a primary callus. It is cartilaginous, and it is done by the chondroblasts. Chondroblasts are invited by these. So they come and start laying down the cartilage bridging periosteal callus, which is a very quick repair on the outside of the tibia or outside of the bone. So you notice an apparent swelling in the area where the bone is healing. Swelling is good because there's a good callus response. If there's no swelling, then it's not going to heal. Then it also commences the medullary callus, which is very slow. Soon after the primary callus response, 2 weeks, by 6 weeks, the secondary callus response starts. They do overlap. The secondary callus response, actually some areas of the bone starts very early, maybe 3 or 4 weeks. But this is a response which is carried out by the osteoblasts. Osteoblasts are the cells that lay down bone. They lay down the hard callus. They eat up the soft callus. The osteoclasts, which are their friends, they eat up the soft callus and they lay down the hard callus. But they don't lay it down systematically like a Haversian system or properly remodeled. They leave it for later remodeling. But this is a hard callus which they start straight after in 2 areas. One under the periosteum, intramembranous, and one inside the medullary canal. So endochondral and intramembranous ossification. That's a good picture to explain. This outer callus is the one which the chondroblasts lay down very quickly within 2 weeks. This is a primary callus. Then there's another soft callus inside which the chondroblasts have laid down. There's a hard callus right in the middle, and there's a hard subperiosteal callus. This is the job of the osteoblasts. Osteoblasts lay down this medullary callus which is dense right in the middle, and they also lay down a surface callus. They need osteoclasts with them to eat up the soft while they lay down the hard one. This is a very nice histological slide which will explain everything I'm trying to say. Imagine this is the shaft of the bone cortex. These are the communications between inside and outside of the bone. This is the original fracture. There's the original fracture. This is the periosteum lifted off. This was the original cartilaginous blue chondroblast laid on the soft callus. This pink is the osteoblast job. They are advancing slowly to meet up the hard callus from the other side. Osteoclasts are on the surface. They eat up this one, and the osteoblasts keep laying it down. So they will meet up. This will be a hard callus on the surface, and there will be a hard callus on the inside. This is a cross section through a fracture. And again, summary as to what I've been saying. Fracture, hematoma, blood collecting around the periosteum, lots of cells coming in, settle down into the form of fibrin clot, initial repair. Then the remodeling starts once the hard callus has been laid down, and remodeling starts from the middle of the repair phase, which is almost three weeks or so, and continues up to 7 years. So there is an evidence of a fracture on a bone up to 7 years, if you can look at it. Woven bone gets replaced by the lamellar bone according to the Wolff's law. Wolff's law is a law of physics which initiates and stimulates the bone laying cells as per the forces of gravity. And when we stand on it, the cells line themselves in that direction and lay down the Haversian system. So the woven bone gets replaced by the lamellar system, which is the circular laying down of the bone. That's called the maximum strength in it. So it takes up to 7 years. Then the marrow repopulation as the bone canalizes in the middle, that's the completion. That means the fracture has now completely healed. This picture may interest you. It's a very good description of bone remodeling. Now we replace our entire skeleton every 10 years. Our entire skeleton is replaced every 10 years by these bone units. And these bone units work in these 6 steps. And they are everywhere inside the bone. They are around 1 million in everyone, right? They're active at one time, 1 million is active. So what happens is that the osteoclasts eat up a bone area there. Now this could be in a fracture, this could be in a normal bone. This is what is happening in a normal bone. But of course when the fracture happens, there is a break. So the same thing goes around and around, but a bit faster when there is a fracture. But what happens in this cycle is that the osteoclasts eat up a pit of bone from here. They eat up and then they die. This is apoptosis, they just fall off. Marginal cells which are sitting everywhere on these shelves inside the bone come and sit in the pit and become osteoblasts. The osteoblasts lay down the bone, they fill up the pit that has been created by the osteoclasts, and then they fall off. So this is a filled up pit, then the osteoclast again sits on the pit and eats it up. So there is a continuous recycling of the bone, and this cycle of course hastens up in any fracture. Problems with fracture healing. Delayed union, that means there has been no attempt at healing. The fractures remained apart and the body didn't try to heal it. Non-union, when there has been attempts on part of the body to heal it, but because of the non-conducive circumstances, mobility, soft tissue interposition, it's still not healing. That's called hypertrophic. Atrophic, there's lack of blood supply to the fracture area, so it doesn't heal up. Non-union, atrophic, non-union. But of course there's an infection, it's not going to join up anyway. It will not only it will become an atrophic, infected non-union. And if everything fails, all the attempts, then you develop a false joint in that fracture area. These are fractures, problems with the fracture healing. That was enough with the healing, how the bone heals. And now I'll go to some examples of upper limb fractures. If you have any questions about the second part, I'll answer them now. Upper limb fractures. The commonest one is a Coltis fracture. You've come across it many times. The Coltis fracture is a fracture of the distal radius. It's the commonest distal radial fracture, mainly in osteoporotic females. But 1/6 accounts for nearly 1/6 of all fractures that happen in the skeleton. First described by this Irishman, Abraham Coltis, in 1814. Remember that he didn't have any X-ray at that time, but he described it because he described the deformity very well and explained how to reduce it. Happens when you fall on your outstretched arm with extension at the wrist around 40 to 90 degrees. So that's why I ask as to how the patient fell. It is completely different as to whether the wrist was extended when they fell on the wrist or was it flexed. Scaphoid injury also happens when it is extended, but it also to be pronated. That's the exact mechanism of how they fall and sustain a Coltis fracture. As I said, it's typical in osteoporotic females. That's the site where the fracture happens. Distal radius, this is ulna. Fracture happens in the distal part of the radius. Remember, this is extra-articular. It doesn't go into the joint. So Coltis fracture, which we call Coltis, doesn't go into the joint. It only involves the distal radius. It is not going into the wrist joint. There is a fracture site. That's the ulna, which is intact. It may or may not be intact with a Coltis fracture. It may have an avulsion of the styloid, but that's the Coltis fracture. On an X-ray of distal radial or a Coltis fracture, what you will see, the things you need to see on an X-ray, and just to remember them, is that the wrist gets wider. There is a widening of the wrist. There is a classic dinner fork deformity, which is like a dinner fork on the dorsum. There's a hump for the distal radius. And the fracture, as I said, is extra-articular and is within 2 centimeters of the wrist joint. There's a loss of radial inclination, which normally is around 25 degrees. Radial inclination, I mean, is that the radius is longer than the ulna because the radius gets shorter, so the radial inclination disappears. There's a dorsal tilting on the normal radius. There is a volar tilting of 15 degrees, but the fractured one points backwards. That's why you have a dinner fork deformity. That's why you hump at the back, because it is pointing backwards. There's loss of height up to 5 millimeter. It shortens, and there is comminution. That means there are more than one fragments, and there could be an ulnar fracture with it. Now the displacement is very complicated in this distal radial fracture. Why it is like we describe it like that? Because when we want to reduce it, we have to reverse all the movements. So there is a dorsal angulation of the fracture. There's dorsal angulation of the distal fragment. There's dorsal displacement. That means the distal fragment not only dorsally angulates, it displaces dorsally. Now it also supinates. Distal fragment also supinates. It also shortens. So it displaces dorsally, it angulates dorsally, it supinates, and it shortens. And it's got a radial translation. So it not only shortens, it comes towards the radius. And then there's a radius tilting. So it also tilts one way or the other. So this is the displacement. What you want to do is, when you want to reduce it, you just have to reverse all these. If you remember these 4 displacements, so you manipulate it under anesthesia, and then reverse the 6 displacements under analgesia and full muscle relaxation. You need muscle relaxation because there are lots of tendons running in front and behind it. That is the way to reduce it. You apply traction. One gentleman is holding the lower humerus, and the other one is shaking hand with the patient and doing a traction. Then this chap who is shaking hand is doing hyperextension at the fracture site, not at the wrist, but at the fracture site, to dislodge the displacement. Then he does the flexion to take away the extension. Then he does the ulnar translation to take away the radial translation. Then he does the ulnar deviation to take the radial deviation, and then he finally pronates it to take away the supination. So that's a stepwise reduction of that fracture, and then he has to hold it in a plaster. The plaster has to be a molded 3-point plaster, and leaving the elbow free to be able to move it. I always split the plaster to allow the swelling to happen, and then complete it a week later if the reduction is fine. Not all the fractures can be held with a plaster. Some of them require percutaneous K-wires that not only can hold it but also reduce it. Remember, we are on the hold. We have done the reduce bit. Now we are on the hold of the distal radial fracture. Not all of them will be held with the K-wires. Some of them need plates and screws. And some of them will need external fixator. The last step in any fracture management is move. Reduce, hold, and move. This is the third one. How we complete our move requirements in the distal radial fractures, we leave the elbow free, so we can move the elbow. We explain to the patient to do shoulder exercises, so the shoulder doesn't get stiff while they're held in a sling for the wrist fracture. Finger movements are encouraged to improve the circulation in the forearm. Now nowadays we have hinged external fixators that are applied across the wrist, so we don't have to immobilize anything. Even the wrist can be moved because there is a hinge on the external fixator. It is holding the fracture but allowing it to move it. Very ideal. I'll give you a few complications of Coltis fracture, which you might have come across. You have reduced it, and it just redisplaces and joins up in a malunited position. Subluxation of the radioulnar joint, because it's not only got a wrist joint there, a distal radiocarpal, but a radioulnar joint. Extensor pollicis longus rupture, very well-known complication of a distal radial fracture. The thumb suddenly drops in a plaster 6 weeks down the plaster treatment. The extensor pollicis longus ruptures, rubbing against the fracture. Wrist stiffness, if you don't move it early, if you don't look after the move part of your management, same thing will happen. Reflex sympathetic dystrophy, again, can happen if you don't move it quickly. Carpal tunnel syndrome, because the median nerve is at the front, known complication of any distal radial fracture. So that's enough with the distal radial fracture. नासिर मेरे पास टाइम है अभी है तो फिर इसके बारे में डिस्कस तो करें कोई सवाल पूछे डिस्टल रेडियल फ्रैक्चर के बाद फिर मेरे पास तो एक सुप्राकॉन्डिलर फ्रैक्चर है उसके बाद एक ह्यूमरस का फ्रैक्चर है 3 फ्रैक्चर्स अपर लिम्ब के मैं आपको बेसिक पढ़ाने आया था बस फ्रैक्चर्स पढ़ लिए हैं उसके बाद इनकी मैनेजमेंट साथ साथ सो ये आज quite common in children and it's at times very difficult to decide when to interfere and when to refer, especially in children, because it's a bit it's very mismanaged fracture. And I've actually within the last 2 weeks I've done cases for gunstock deformity or malunion of the proximal humerus, again of the distal humerus, because of this supracondylar fracture. Okay, shall I carry on then?
You have 1 hour.
Yeah, but that I may finish earlier than 1 hour. If I'm going too fast, then please stop me. I'm all right? This is a common fracture in childhood. As you all know, it's a fracture of the humerus above the condyles. Again, this is not an intra-articular fracture. This is a fracture of the humerus just above the condyles. And the distal fragment mostly gets displaced posteriorly. This is a common knowledge. The distal fragment doesn't come for volar but dorsally because of the triceps at the back and the gravity. The factors that displace any fracture, as you remember, is the initial injury, the muscle force, and the gravity. Now, risk of damage to the brachial artery is fairly high in these fractures because not only of intimal damage to the brachial artery, but also because of the hematoma as a result of the fracture. This should be treated promptly. You cannot ignore this fracture. You ignore it for 2 days, you will find a completely different picture. It will not reduce. It has already started healing. In children, the initial soft callus really starts very, very quickly. It almost have to re-break it at 3 weeks. You have to re-break it to reduce it. It won't reduce at 3 weeks. It's too late if you take it more than 2 weeks. So it has to be reduced straight away. And then it will be a very stiff one. Even if you reduce it at 3 weeks, it will be a very stiff elbow. Clinical examination. Just a revision of our initial method of clinical examination is look, feel, and move. So what do we look at? A fracture of the supracondylar area of the humerus. There will be a swelling. There will be an impending skin violation because of the bony fragments pushing on the skin. As you know, elbow from behind is subcutaneous, so fragments can be pushing on the skin. There will be an apparent deformity. There may be a wound. But the clue to all of this is to expose both the elbows and compare the amount of swelling, the alignment, the angulation, and the filling up of the normal fossa. Unless you compare it, you will miss out things. So always expose the other elbow. Then you feel. You feel for pulse. Pulse is important because brachial artery is very close to it. Look at tenderness. If there's any tenderness, remember the wrist and the shoulder. So the joint above and joint below always need to be remembered, especially even not only in an X-ray but in clinical examination, because there could be a concomitant injury of the shoulder. Then you move it, and as you move it, it is painful. There will be a restriction of the movement. There may be a crepitus. There may be loss of pulse when you move it. That's the fracture anatomy. This is the area of the fracture. Distal humerus, fracture within 2 centimeters of the joint, condyle, distal fragment rotating in the horizontal plane, externally rotating. In the coronal plane, going into valgus. In the sagittal plane, going into extension. So that's the displacement that happens in this fracture as per the muscle pull, the gravity, and the initial injury. Here's an example. This is not a grade 1 but a grade 2. A grade 1 fracture would be well aligned, still here. It will still be here. Now this is grade 2 because it is dorsally displaced. Distal fragment is dorsally displaced. It's dorsally angulated, it's dorsally translated, slightly shortened. The radius is in line with the capitulum. The ulna is on the trochlea. The only displacement is at this level. So this is an extension type of supracondylar fracture. This cannot be left here because you can't flex. As you flex, the radius hits this condyle and there will be limited flexion. This needs to be reduced to improve the function. This is grade 3 of the same, when the fragment doesn't stay any near the proximal fragment but displaces dorsally completely. So this is a grade 3 extension type of fracture. This of course needs something doing definitely. There's another type of supracondylar fracture which is a flexion type. This is the only picture I could find of it. In this, the distal fragment is volarly displaced, and the proximal fragment comes anteriorly. See, the ulna goes behind, the humerus goes behind, and the distal fragment comes anteriorly because of the pull of the biceps here. And it happens when you fall on the point of your elbow there, and the distal fragment comes forward. This is a rare flexion type of fracture. Again, supracondylar fracture needs to be realized when you're manipulating, because the manipulation activity is going to be reverse of what you will do in an extension type. It happens as a result of a direct fall on the elbow. Now, how do you manage this? The undisplaced one, in which I said there's no malalignment, can be managed just in a sling for 3 weeks and it will heal. You don't have to do anything. An extended one, which is slightly angulated but not completely displaced, needs to be reduced and then held in a collar and cuff sling if it is stable. If it's not stable, then you have to put some wires in it. Extended ones with rotation and disengagement, the third picture I showed you, needs to be reduced, open reduction, internal fixation, and needs to have 2 K wires across them to hold it. So reduce and hold again, reduce and hold again. Then the third bit is to move it. This is flexion type rare, again needs the K wiring. This is how you reduce it. Supracondylar fracture, which has got grade 2 extension type, not completely displaced, you apply a longitudinal traction, right? This is the surgeon, that's the assistant holding the distal femur. He is pulling longitudinally, the arm is in neutral supination. These hands correct the lateral and medial displacement. This here corrects the rotation. This thumb corrects the extension. So there was extension, the thumb is pushing it forward. As the arm is flexed, it corrects the extension, and then this pronation locks everything. So see, now the wrist is in pronation. So in the end, the wrist is pronated, so everything is locked, whatever reduction you have performed. So this hand is now pronated. So now the fracture is reduced and it is held in pronation here. Now you have to hold it with a sling. How do you hold it? First we thought we'll hold it with the K wires if it's completely displaced. That's one way to hold it. In the grade 3 ones, 2 wires, one on either side. This is the AP view, and that's the lateral view. These wires are outside the skin. They're pulled out at 4 weeks time. Just pull them out in the clinic. And what is the subsequent management? Total immobilization is around 6 weeks, and that's how you immobilize. Just notice that there's this band going around the elbow saying don't open the elbow. No flexion is allowed. No extension is allowed. It is reduced in this flexion. So there's a figure of 8 bandage to stop extension. There is pronation of the forearm to lock the fracture. There is flexion at the elbow, and it is kept in internal rotation. The hand is kept close to the chest. Complications again of supracondylar fracture. I'm sure you remember the complications of distal radial fracture, which we did a few minutes ago. Volkmann's ischemia. Volkmann's ischemia is a compartment syndrome of the forearm. There's a whole vicious circle when this happens. Fracture happens, the artery gets damaged, either intimal or it bleeds. There's local ischemia. That leads to edema, of course. And compartment pressure rises above 30, 40, local arteriolar pressure. The pressure reduces the local blood flow further. There's further ischemia. So this ischemia comes back here. So it starts again, edema increases. So this is a vicious circle, carries on until the muscles start to die and the patient's arm is got severe pain, there's pallor, there's pulselessness, there's paralysis, and there's paresthesia. 4 P's of Volkmann's ischemia, impending Volkmann's ischemia. Soon as the compartment syndrome develops, you need to take everything off and do the fasciotomy. Other complication is the loss of reduction. You've done a complicated reduction, but it doesn't stay there because your immobilization wasn't adequate, your wire wasn't good enough, your reduction technique wasn't right, so you lose the reduction. The median nerve can be injured again, like the brachial artery can be injured. Malunion, very common, late presentation, varus or valgus. Or this happens because of epiphyseal injury. So one side of the distal humeral epiphysis stops growing, the other side keeps on growing, and the angulation starts to develop. Rotation can remain uncorrected again. Stiffness, another complication of heterotopic ossification. Elbow is very unforgiving for any injury or manipulation. So that's why I don't manipulate stiff elbows, because as soon as you manipulate them, they develop this bone around the front. So there's no point manipulating any stiff elbow. It's either surgically released or you have gentle physiotherapy there. There's one example of heterotopic ossification. Had a fracture there. See, the fracture wasn't bad. It healed in good alignment, but the amount of new bone formation at the front doesn't allow the forearm to move. So this was the hematoma at the front that has ossified. Known complication of supracondylar fracture. This is one of the patients which we did here recently. This is a fracture of the supracondylar area in a young 12-year-old, and is now presenting with varus. See the line of the humerus and the line of the ulna? The ulna is in varus. Normally, the forearm is in valgus in all of us. So in girls, especially around 15 degrees valgus at the forearm. But this is in varus. So this is called gun stock deformity. Her lateral elbow is prominent on the one side. Because the growth on the outside carried on, the inside growth stopped, so the outer part became longer, led to this. Not only that, the anterior part of the epiphysis grows more than the dorsal one, so you develop an extension at the fracture. So the radius capitulum normally inside the line is behind. Humerus is there, but the radial capitulum is behind. So she's got an extension malunion and she's got a varus malunion. Known complications of this supracondylar fracture. Any questions on that? Supracondylar fracture. Now I'm sure you can manage a supracondylar fracture. If it comes to your clinic, you're going to look at it as to what grade it is and what you should do about it. You want me to go on to the proximal humeral fractures? If you have somebody, young person with an injury around the elbow and there's a big hematoma, don't flex it. Because the moment you flex it, the pulse in the radius will go. So flex it to an extent while feeling the pulse and then put them in a sling. And then maybe flex it up, you see the pulse goes, then go down and put it further centimeter down. So it allows for the swelling, keeps the blood supply to it. Then of course it needs to be referred for an X-ray and subsequently managed. But what you can do is actually not to make it worse by not flexing it. Because the moment you flex it, the artery will get impinged further. But the best thing to do is actually assess the artery at the time when you examine, assess the nerve at the time when you examine, so we know that the damage to the vessel and the nerve wasn't because of the primary injury, or it was because of the primary injury, or was it iatrogenic when the surgeon manipulated it. So you need to know when the problem happened. So if you can avoid making it worse, that would be very good. Okay. Can the lights down? Just to revise your anatomy, this is an X-ray of one of our skeletons. Proximal humerus, subscapularis coming from the front of the scapula, attaching on the lesser tuberosity. Long head of biceps coming from the supraglenoid tuberculus over the head, going into the intertubercular sulcus all the way down, biceps, and then supraspinatus. This button here is the supraspinatus. That is the coracoid, That's the correcoclavicular ligament. That's the clavicle. That's the acromioclavicular joint and its ligament. So that's the proximal humerus anatomy. That's the joint surface there. That's the anatomical neck. There where the joint finishes, anatomical neck. Where the insertion finish, surgical neck. Lateral view, long head of biceps there running down, supraspinatus, acromion sitting up like a shelf on top of the humerus. That's the greater tuberosity. That's the lesser tuberosity. Again, correcoclavicular ligament and the coracoid. So you see the arch here, coracoid, correcoclavicular ligament and acromion. It's like a cup on top of the humerus. It's a secondary joint on top of the rotator cuff. So that was enough for the anatomy. So what parts there can be in a fracture of the proximal humerus? There could be one part which is the head, and the other part could be a greater tuberosity, a lesser tuberosity, and the shaft. Hence the fractures can be 2, 3 or 4 part. Simple way to identify a fracture of the proximal humerus could be 1 part, 2 part, 3 part or 4 part. There is no 1 part fracture because it's not a fracture. It has to start from 2 part. There's an example of a 2-part fracture, and I think it's also got a lesser tuberosity fracture. It's a 3-part fracture. Shaft of the humerus, head of the humerus, and then there's a lesser tuberosity fragment. That's part of the acromion. That's the glenoid. So it's in the joint. There's a glenoid joint. So it's got 3 parts, 2 or 3 part fracture of the proximal humerus: shaft, head, and lesser tuberosity. How do you manage these fractures? Undisplaced fracture, undisplaced 2-part fracture can be managed conservatively in a sling, and the gravity helps us here to reduce the fracture. It's a good time when we use the gravity to help maintain reduction. Start moving early. Same principles. Reduce, hold and move. Already reduced, so we hold it and we move it. Start early range of movement exercise. Second difficult one, displaced 2-part fracture. It can also be managed conservatively if the displacement is not more than 1 centimeter or the displacement angulation is not more than 45 degrees. That's my criteria. So if we do not manipulate all of them, so we just accept it as reduced if the displacement is within those limits. But if it is more than that, reduce it, do a manipulation. If it is reducible, and then hold it in a sling, again reduce and hold as above, and start moving it with caution and delay. If it's a 2-part fracture, for example a fracture of the greater tuberosity, the supraspinatus muscle pull will keep on displacing the greater tuberosity, so you move it with caution. Tell them not to abduct, tell them not to externally rotate, so it will hold the tuberosity in place. A 2-part fracture, both conservative management. When you require open reduction and internal fixation in a proximal humeral fracture, when you need a surgeon, when the 2-part don't stay together or they are irreducible, when the fracture is 3-part, that means head, shaft, 1 tuberosity, head, shaft, 2 tuberosity, 4-part fracture, that's when you need somebody to fix it. Sometimes you need to replace the whole joint if the fracture is very bad. If it's comminuted, if it's osteoporotic, cannot be held by any implant. The screws don't bite, it's like cheese, the wires don't hold because everything is soft. So that's when you need to replace the entire joint. That's why I do the hemiarthroplasty. Similar to, like, because of this failed open reduction or an impossible open reduction. Lack of available expertise of this instrumentation is again an indication of hemiarthroplasty. I would do half a new joint rather than take the patient through a difficult surgery and still not get the fractures healed up together, fragments. So I may just replace the joint in an elderly person. Humeral shaft segmental fracture, an example there, which you have seen this X-ray, fracture shaft there, surgical line. No other option but to refer and have it done, something done to it. That's the lateral view. It's still in the joint, but that's the lateral view of the same. So you need to fix it. That's what we use, a long plate and a blade in the head, lag screws, some bone graft, lag screw there. It's fixation of the segmental fracture. Complications again. Rotator cuff is an important structure here. They're comprised of the supraspinatus, the subscapularis, the infraspinatus, the teres minor. All those muscles that move our shoulder are called rotator cuff, and they can have an injury because of the primary assault or while you are doing manipulation or surgery. These are known complications. Axillary nerve injury, very well known but fairly ignored, deltoid palsy. Axillary nerve supplies the deltoid and runs around the surgical neck. Any surgical neck fracture can damage it. Any surgeon's retractor around the medial side of the proximal humerus can cause axillary nerve injury. That's why it's good to examine before we operate as to the integrity of the axillary nerve and the radial nerve. Failure of fixation, known complication, that plate may just go loose and just not let the fracture heal and may break. Non-union is not very common here because it's very well perfused area, but non-union can happen if the immobilization is not adequate. Infection, in our setting, we do give them lots of antibiotics, but still MRSA infection, still common and hanging around the implant. Sometimes the infection does happen, but I leave the implant for longer until the fracture heals and then remove the implant to get rid of the infection. Damage to the vessels, all the vessels to the upper limb, brachial artery, axillary artery are nearby, near the surgical neck, so they can be injured. Stiffness if you don't move it on time. Known complications of proximal humeral fractures. Thank you very much.